Okay, to continue what we stopped in the last recording about the biopharmaceutics and pharmacokinetic, we stopped at the point where we were talking about the ADME and the processes, its definition. This is the what we said here in this slide is the one sec is the basic um, definition of kinetic. It's the basic science of kinetic. When we go through the specification or more into details of the pharmacokinetic, you'll find that okay, the interest is not only just studying the kinetic. There's something that we call it clinical pharmacokinetic. Uh, this is the one or the other course that we take usually with PharmD student as a second course of kinetic, in which why the clinical pharmacokinetic is important, because usually the clinical studies um, uh, include patients or individuals with variation. Either it's an intra-subject variability or inter-subject variability. Those the large variation or different variation or uh, wide spectrum of variation between subject or in the same subject, him or herself, uh, considered if we consider those kind of variation, we need to have that specific science that consider those kind of variation. Okay, so if we are talking about the kinetic as the major umbrella, one of the um, let's say specified pharmacokinetic studies is the clinical studies, which is an application of whatever that you will know as modeling or method of a mathematical methods of studying the drug, but we optimize those kind of things to certain either individual disease or individual therapy or individual race. So we are taking into consideration all the differences that we will have, either age, gender, race, genetic differences, disorder, female versus male, kidney disorder, let's say, um, Middle Eastern versus Western societies. Those kind of things are the clinical kinetic um, science, which is again, it's a pharmacokinetic science, but it's just more specified to the differences or variation that we have inter and intra uh, um, between subjects or in the same subject. So inter individual or intra individual. Population kinetic, it's the study, or it's a clinical kinetic, but in which we are studying it in certain population. Let's say we are studying the um, let's say prognosis or diagnosis or the distribution of blood pressure in adults, but we are talking about ages between 30 and 40, let's say, Jordanian or like in north of Jordan, and or even in Jordan itself, and they are healthy other than the blood pressure, so you are taking different factors or specified clinical factor in this kind of population. So all of those terms related to kinetic or pharmacokinetic, which is the basic science that we usually started to understand the kinetic of the drug. Then we go to study it in certain under certain conditions or situations or cases, and then in certain populations, so it will be a population kinetic. Okay, the pharmacodynamics, again, it's from pharmacon, which is the drug, okay, and dynamics, which is related to the dynamics of the drug. Usually, again, as we study pharmaceutics first, in biology first, then we combine them together to understand the biopharmaceutics of the drug. Then we study pharmacokinetic of the drug. There is a pharmacodynamic of the drug, which is which comes usually after the pharmacokinetic of the drug, in which we study the relationship between the concentration of the drug but at the site of action receptor, or what we sometimes call it the bio phase of the drug, and its pharmacological response. So we have in pharmacokinetic, we have concentration, right? We have concentration versus time. We study the effect of the drug or the kinetic of the drug in different processes. So we have concentration versus time. We take this into consideration and we have some information out of it. Then we need to know what is the concentration of the drug, or let's say here the concentration of the drug, okay, versus the effect of the drug. Okay, this is effect of the drug. So we will have whatever the profile that we have. So we study the relationship between the drug concentration and the response, or the effect of the drug, and anything that is related to this relationship will be studied under dynamic of the drug. And usually we are studying whatever is happening to the drug and receptors to give us the sufficient uh, efficiency, which is the maximum effect that we want, with the lowest toxic response that we have. Okay, and here this diagram is summarizing whatever we just said about the biopharmaceutics, pharmacokinetic, and pharmacodynamic, and just boxes in rows. So we will have the absorption. Let's forget about the boxes. We have the absorption, we have the elimination, which includes excretion and metabolism, and we have this, which is the reversible process, which is the distribution. So kinetic wise, we have, let's keep it in red, we have absorption, we have distribution, and we have excretion and metabolism. Okay, in biopharmaceutics, we said that in biopharmaceutics, we are talking about the pharmaceutics of the drug, or anything that is related to the pharmaceutics of the drug, factors that is related to the drug and its manufacturing and drug delivery and so on and so forth, where the relationship and its relation to the physiological or biological environment, which is in more concern, we are usually in more concern with bioavailability or the drug extent and rate of absorption of the drug. So usually the importance of the biopharmaceutics is at this side, in which we are studying whatever is happening to the drug as release and dissolution. So this is something related to biopharmaceutics, biological part, and then the absorption will happen to know the bioavailability of the drug. But if we are just to the basic definition of biopharmaceutics, we will find that biopharmaceutics involves in all of that to understand whatever is happening to the drug. So in here, we usually have a biopharmaceutics, and we are talking about the relationship of the concentration of the drug at the site of action. Let's consider it the tissue or organs in here, and whatever that we have as pharmacological or clinical effect, then we are talking about the the pharmacodynamic of the drug. So we have biopharmaceutics, we have pharmacokinetic, and we have pharmacodynamic of the drug. And we have interrelationship and interaction and overlap between all of that, as we have interrelationship and interaction between pharmaceutics and biology and physiology and anatomy, all of that. We usually, as I said, we understand the pharmaceutics of the drug, then we study the biopharmaceutics of the drug, then we study the pharmacokinetic of the drug that continues to take us to the pharmacodynamic of the drug, at which we end up with the this section or this compartment or box that we want to understand what is the pharmacological or clinical effect. So the ultimate goal from all that to reach the point in which we can say that we have the maximum effect, pharmacological effect of the drug with the least toxic effect that we can have. Okay, as we mentioned in this slide, we said that we have different experiments, we have different sampling, and we have different kind of sampling techniques and analysis. This is a little bit some kind of I won't say a summary, it's just kind of headlines about the sampling that we have in different sampling media or matrices that we have in the analysis of the drug. So if we want to measure the concentration of the drug, we have different samples. And when we are saying samples, it's anything that you can take. And again, some of the samples you can take from the living human or living animal, but other samples, if we have like killing for the animal, we can harvest anything. So the samples can be milk, saliva, blood, urine, feces, skin, hair, um, uh, organs such as liver, kidney, lung, heart, anything. Okay, so any sample that you can take. For sure, the most common sample that we can have is the blood, which could be whole blood, plasma, or serum, and we will talk about this in a minute. And then after that, we will have the urine and feces. Okay, other samples are usually uh, determined according to the case that we have, or if we are concerned about the drug, if it's going, let's say, preferably to the hair. So we study the hair, so we have samples of the hair, or go to the nursing milk. So we study it and the milk. So it depends, okay? So analysis of the samples, any kind of analysis method that we need to do it. But most frequently or most commonly, we have chromatographic uh, method of analysis. And I think you took analysis method or instrumental analysis so far, and you know that we have so many ways to analyze these samples. As a kineticist, you need to have some kind of understanding and mastering of the sampling process, especially in the research field and the analysis method. Okay, so you need to have that kind of understanding, or you need a great collaboration with other department if you are talking about clinical pharmacokinetic studies and having that in a human. Sampling of biological samples could be invasive or non-invasive. From the name, it could be as no invasion or no intervention to the individual that we are talking about, or just we have some kind of intervention in invasion. When we are talking about invasion, it could be as simple as needle. Okay, so it's anything that is related to intervention to the patient. So blood, even, it's very common and very the most common sampling procedure, but it's considered as invasive because we are using needles. Spinal fluid, because we are using needles. Tissue biopsies, because we are using some needle intervention to take those kind of samples. When we are talking about non-invasive, it's the sampling procedure that we are doing without doing any intervention to the patient. We can have the sample ready and or out of the patient or individual body without having an intervention, like feces or urine. The feces and urine already are out from the body of the patient or body of the individual without you enforcing it to take the samples. Expired air, let's say saliva, some of the dead skin swabs, swabs from the intranasal, um, sweat, milk, all of that, it's already, the samples are already out of the body without any intervention. And again, being invasive or non-invasive method of sampling, it's not related to being convenient or not to the patient. For example, for the individual, usually they are more comfortable with blood sampling compared to the urine sampling or the milk sampling or the sweat sampling. It depends on the perspective of the individual that we are talking about. Let's start with measuring the drug or concentration of the drug in blood, plasma, or serum. It's most direct procedure, and as I said, it's one of the most common, and it's usually choice number one in sampling for kinetic analysis or for kinetic studies. We either had whole blood, serum, or plasma. When we are talking about whole blood, from the name, it's just the sample that we have at the beginning, which includes everything. Okay, everything, RBCs, white BCs, the clotting factors, proteins, everything that is involved there. And again, the choice, rather than whole blood, serum, or plasma, it depends on the target of your study. If, let's say, you are studying sickle cell anemia, you are interested in something related to your RBCs or the individual RBCs. So you need to segregate or separate your RBCs from the whole blood. If we are talking about something related to white BCs, then you need to take your white BCs and sometimes to even to divide them to the type of white BCs that you have. So it depends on the study, but usually the most common, we either have whole blood, serum, or plasma. As I said, whole blood includes everything. Serum or plasma, um, the serum, we have the whole blood that we already took, that includes everything. We keep it a bit for clotting, okay? And there's timing, a specific timing for that. And it's different from model to model, human to animal. But anyway, we just take the sample, whole blood samples, and we wait for time to clot, and then we do a centrifugation and we take the supernatant. So you have the sample of the whole blood, you leave it a little bit to a clot, then you centrifuge. You'll have uh, the precipitate air or whatever the viscous material down, and we have this. You'll take this and it will be the serum, and it's a yellowish transparent liquid. Okay, so the serum would be the blood without the cells and without clotting factors, because we allowed the blood or the sample to clot. The only difference in the plasma, that we are taking, we do the centrifugation and we take the supernatant of course, the centrifugation of the whole blood, and we take the supernatant, but we add before anticoagulant. So, okay, we don't have this step. We add the anticoagulant. So the plasma, it will be the whole blood without the cells, but the clotting factor are still there. So the content, the only difference is the content of the protein, including the clotting factor between serum and plasma is the difference, and between whole blood and serum and plasma is related to whatever that we lose as cells and the centrifugation process. Okay, so it's a protein content. In this course, you'll find me talking about concentration in the blood versus time, concentration in the plasma versus time, concentration of the serum versus time. We don't have a specific reason why we do this or that, because we are studying the basic science. When you do your own study or research, you'll get a little bit flavor about this, why you do this and that. It's mainly related to your drug and the distribution of your drug and the target of your study or the hypothesis of your study or the outcome that you are waiting from your research. Okay. We have this slide is very important, in which we have one of the major assumptions that we have in the kinetic modeling and kinetic studies, in which we are considering or assuming that the drug in the plasma or the serum or the systemic circulation, it's in dynamic equilibrium with the tissues. Again, it's equilibrium. It's not equal. It's not the same. It's just equilibrium with the tissues. The drug and the plasma or serum or biological fluid that we are measuring under equilibrium with the drug at the site of action or tissues or organs. This assumption is very important because we are, according to this, we are studying the concentration of the drug versus time. And again, this is measured, let's say, in plasma serum or any biological fluid, and we can reflect that to whatever is happening to the drug at the site of action. Okay, so this is very important. And again, this is usually the case and or the general case. This is the rule of thumb that you have in and the studies, but we have some kind of exceptions for that as any rule or any assumption. But we will talk about this later. Usually, the concentration of the drug and the measured fluid reflect whatever is happening to in the site of action. This is what we call it kinetic homogeneity, or the homogeneous kinetic principle, in which the concentration of the drug at the site of action proportional is proportional to the drug concentration in the blood. And this is not always true. This is important. We have some exception to that. Why this assumption is very important? You need to think about it in a way as experimental way. Why it's important that the concentration of the drug that is measured in the biological fluid, mainly in the systemic circulation, is in an equilibrium or at equilibrium with the drug concentration at the site of action. Why? This is very important because we can't we can't experimentally almost always to measure that drug at the site of action. Again, in some experiments, in some models such as animal, we can do that, but to harvest the organs, you need to kill the animal. In human, we can't do that. We have some kind of insights from animal models, but it's not always true. So we have this assumption because it's help us. Even again, it should be true, not the exception. It helps us to understand whatever is happening here because we can do it experimentally. We can take samples. We can't analyze samples from tissue. Let's say we have brain tumor. We are studying brain cancer. Okay, can we take brain samples from healthy and diseased patient? No. So we usually use this assumption to help us in our studies. Okay. For kinetic, in general, as we said, we will have different data point or an experimental point that we have at different time point, and we measure the concentration. Okay, we have what we call it the model, the mathematical model, all the or the profile. Sometimes we just call it the profile or just the model or equation, model equation. All of that is related to, as we said in the previous recording, it's the theoretical part of the model. So we have the experimental part, the points, this arrow on the point, and the theoretical part. Okay, so we have this kind of, this is concentration versus time, that is kinetic, right? So this is the pharmacokinetic of the drug. From the kinetic of the drug, we can understand other important things related to the drug. Just by knowing the minimum effective concentration and the minimum toxic concentration, which determined by the therapeutic range of the drug, we can know from the profile of the drug that we have here, concentration versus time. We can know the onset of action, and we can know the termination time or termination of the drug action. Onset of action de- de- dependent on this. It's just let's say explaining diagram. We don't have numbers, so minimum effective concentration is here. Okay, the concentration that is equal or more the minimum effective concentration will be once the concentration of the drug equals or more than that, or start to be more than that, this is the onset of action of that drug. At the time the concentration of the drug is start to be below the minimum effective concentration, it's not active anymore. Okay, and the duration of time between the onset and the termination of the action is called the duration of action of that drug. Those are just clinical terms that you already know, but maybe you didn't link it to the kinetic of the drug. By knowing the kinetic of the drug, knowing some kind of clinical information that we already know about our drug, then we can determine onset, determination, and duration of action. There is a lot of parameters that we know, which is called kinetic parameters. Pharmacokinetic parameters relate to the drug. Examples on those parameters, and we will talk about this again in details, a bare model that we are talking about, but examples, the peak concentration or the maximum concentration of the drug. What we mean about that, it's the maximum concentration or the highest concentration that we can reach. And this is one of the parameters, which means that after we do the model, we can identify or define the model with this. We can say that ciprofloxacin has a Cmax or C peak that is equal to this. Okay, the peak time or maximum time, which is the time at which the maximum peak that is happening, and again, it's called Tmax or the peak time. Okay, we have what we call area under the curve, which is the area that is usually measured or calculated under the profile of concentration versus time. Those are the what we examples on what we call it pharmacokinetic parameters of the drug that we usually use to define the drug. And if you open any leaflet or package insert of any drug, any antibiotic, any drug that you have, and go to the pharmacokinetic section, you'll find that it informs you with this drug has a Cmax of this and that, Tmax of this and that, distributed with this time, eliminated with this time. Those are pharmacokinetic parameters and pharmacokinetic information that we usually use to define the model. What we use those kind of things, we will talk about it later, but the peak concentration we usually use, it's very important to determine the extent or rate and or the rate of the drug absorption. The peak time, it considered a main factor to determine the rate of the drug absorption, and area under the curve is usually important to determine the extent of the drug absorption. Okay. For drugs, the concentration in tissues, as I just mentioned a couple of minutes ago, that it's hard and it's not feasible all the time to take samples from tissues because it's tissues and it will be drastic. So that's why we usually use tissue sampling when we need to, such as tissue biopsies when we want to do a diagnosis for certain disorders or certain malignancies or tumors. Okay, usually in tissue biopsies or tissue sampling, which is common sense, we have very tiny size of the tissue. Therefore, the concentration of the drug is very small, would be very small in those sampling, and accordingly, the analysis will be very low in those sampling or samples if we are talking about tissue sampling. Okay, that's why it's one of the difficult samples to do if we are talking about living individual. And also the drug concentration in certain part, if we're talking about, let's say, disorder in kidney, and we took the or lung, let's say lung, and we took a sample, which is a biopsy, which is very tiny small amount of the sample from the upper lobe of the lung. It doesn't mean that the concentration of the drug in that part that we took is the same in all parts of that organ, the lung, and also it doesn't mean that whatever that we are having in that part is the same in all parts of that organ, which is again common sense. But those kind of things that we usually do for diagnosis rather than determination of the concentration of the drug in those biopsies. So there's disadvantages related to the feasibility experimentally to take samples from tissues. Drug concentration in urine and feces, as I said, it's both of them are considered common sampling because we usually have it after the blood or systemic circulation sampling. It's usually used for what we call it the mass balance studies or mass balance analysis. Mass balance. Okay, mass balance studies in which you have 100, let's say, milligram of the drug entering your body, or the individual that you are studying, you took 80% of that in the blood. You need to know what is ever is happening to the other 20%. Okay, so usually we are talking about other biological samples. So urine and feces is one of the major samples that's going out of the body. So this is what we usually do. We study whatever is happening in the urine and we study whatever is happening in the feces as yield a few as you do in the labs. You have the yield percentage to understand whatever that is happening to the drug in the first place. You measured whatever in systemic circulation and you want to know whatever is happening in the other parts or samples in the body. So usually in the urine, it's important in bioavailability studies, and we will see that in the bioavailability chapter. And feces, we usually talk about the either the excreted and the bile or the not absorbed drug. Is just excreted as unchanged drug and the feces. So it depends on whatever is happening to your drug. You can consider the samples or the study of the urine or the feces. And again, we have other samples, as I mentioned, it could be milk, it could be air, expired air, it could be sweat, it could be nails, it could be saliva, it could be anything, hair, it could be anything that you can take, but this is, or those are the major samples that we usually take or you usually hear about in a clinical setting. Okay, and I will stop here, and inshallah we will continue with the PK modeling next time.